Thank you, chairpersons, for your kind words. Thank you, Manoj and Purvi, for this invitation to speak on a very interesting subject, which is the interaction between diabetes and cardiovascular disease, which is frequent, forgotten, and often fatal complication of diabetes. This was the editorial written in Diabetes Care in 2003, and that's what we're going to discuss today. So we now get to 1979, almost 47 years back, when the Framingham Heart Study for the first time demonstrated the association between cardiovascular disease and diabetes for the first time. And now they said that the high sugar was taken as blood sugar of more than 150. That was the cutoff point they used to diagnose diabetes at that time, way back in 1979, showed the association between cardiovascular disease and diabetes. This is the global data looking at more than 4.5 million patients. And what it tells you that the incidence of diabetes and cardiovascular disease is pretty common. If you see, for example, 1 out of 3 patients have some cardiovascular disease, 1 out of 5 will have coronary artery disease, 1 in 7 will have heart failure, 1 in 10 will have myocardial infarction, 1 in 13 have stroke. So high burden of vascular disease in patients of diabetes is very evident for these prevalence studies. This is data again from India, which looked at more than 5,000 patients, a new onset diabetic patient, and it looked at the possible cardiovascular disease risk in these patients. And what it looked at, the high-risk patients and a very high-risk patient, you'll be surprised to know that 40% of these patients of new onset diabetes have a high risk of cardiovascular disease, and 60% have a very high risk of cardiovascular disease when they're new onset diabetic patient. And that's why you see the life expectancy is reduced in patients of diabetes by 6 years with the diabetes alone. It has, along with the cardiovascular disease, is reduced by 12 years. And with kidney disease, it reduced by 16 years. So that's how the reduction of expectancy of life. We have either diabetes with heart disease or with the kidney disease. And we know that diabetes is a very complex disorder. We know that type 2 diabetes, kidney disease, and of course the cardiovascular disease is the most important risk factor for the problems of cardiovascular outcome and the expectancy of life when you look at patients of diabetes. You can see here that large number of patients have all these diseases together. And what is very interesting is that one disease interferes with the other negatively. That means if you have a heart failure, it worsens your type 2 diabetes. Type 2 diabetes worsens the atherosclerotic cardiovascular disease. That in turn worsens chronic kidney disease. And all of this to be taken holistically. You need to treat them totality, not in isolation. So therefore, it's important to realize that this is a very complex disorder. And these are the risk factors. We all know them. That either it's obesity, age above 50 years, hypertension, smoking, and dyslipidemia are the standard risk factor that you see in patients with diabetes with ischemic heart disease. This is a very interesting study, the old study Mr. Fit trial, which looked at more than 350,000 patients. In that, about 5,000 patients were diabetic. They looked at 3 important risk factors. The risk factor could be hypertension, more than 120, presence of smoking, these patients, and the presence of the obesity. And when you see all the 3 factors together in a patient of diabetes, the dark line or dark bar that you see, that more the risk factor, more are the cardiovascular event in these patients. Therefore, every event contributes immensely to the cardiovascular outcome in patients of diabetes. This is the Indian data which looked at the prevalence of dyslipidemia in this country, which looked at north, south, west, and east. And you see that the high prevalence of the dyslipidemia in terms of triglycerides excess and low HDL. You can see the low HDL is to the tune of 60% that we have. Our population has this disease. This could be epiphenomenon in this country where we have low HDL, high triglyceride, which is a very important risk factor for the ischemic events in diabetic patients. And the atherosclerosis that you see in patients with diabetes is also very premature. It comes early because of various factors, and the most important being the endothelial dysfunction, which is produced either because of diabetes itself and hypertension associated with that, and we have the oxidative stress because of the hyperglycemia, which also contributes to the endothelial dysfunction, which is responsible for the early atherosclerosis that you get in patients of diabetes. Hypertension, diabetes are again interlinked quite effectively. You can see that the RAS activation that you see in patients of hypertension and retention of sodium and the sympathetic overactivity is responsible for hypertension. And in patients of diabetes, because of the dyslipidemia, the insulin resistance, hyperglycemia, and the obesity also brings about atherosclerosis. So both put together, the hypertension, diabetes are the cousins inseparable from each other that you see in patients of diabetes. 40% of the patients of hypertension have diabetes. 50% of diabetic patients have hypertension, such a close association that you see here. And furthermore, the inflammation, the endothelial dysfunction, and hypercoagulability also contributes to the problems of ischemic events in patients of diabetes. What is interesting and important to realize that diabetes and heart failure are the two sides of the same coin because both of them have increased sympathetic system stimulation, both have high renin-angiotensin system activation, high aldosterone levels, and high neprilysin levels. And these two altogether drive either the microvascular complications or a heart failure progression. So therefore, it's important to realize a patient with diabetes, the risk of heart failure is pretty high. And you also see what you see here, that the heart has those receptors, which are this transporter, which is called sodium hydrogen exchange transporter, and a similar transporter also exists in the kidney. And the upregulation of these transporters brings about retention of sodium and therefore increased amount of heart failure. And what's also important to realize that insulin, pioglitazone, and saxagliptin stimulate sodium hydrogen exchange transporter, and therefore the risk of heart failure is very common when you use these particular drugs in patients of diabetes, especially those who already have either incipient or obvious heart failure. We all know that type 2 diabetes, cardiovascular disease, and kidney disease is the most important problem or the most important public health issue today of this particular century. And this was driven entirely by the adiposity, which is the excess adiposity, which also dysfunctional adiposity, which results into cardiovascular disease and the kidney disease. And therefore, the American Heart Association in 2023 in the advisory guideline talked about what is called as CKM syndrome, which is very important in patients of diabetes, which is responsible for the cardiovascular and the renal impairment in these patients. They also brought in staging in these diseases because when you have staging, you can find about how much improvement you have created in the patient or how much patient has worsened, similar to what the oncologists do with staging in the cancer. Similar kind of staging is also done in patients of CKM syndrome. So when you want to manage such patients of diabetes, we have the four-pillar approach. You need to have good glycemic control, you need to have good pressure control, the lipid management, and of course the agents which cardiovascular and kidney safety. This is the study from Thailand which looked at 666 patients. The entire idea was to see what happens if you delay intensification at 6 months or beyond 6 months. And it's interesting to see those patients who get intensification much early in the treatment have a less incidence of nephropathy. Even if you delay the intensification by 6 months, the incidence of nephropathy increases by twofold, which is pretty high. And therefore, it's important to realize that you need to intensify treatment much early. And that's what the message from this particular study. This is the American Diabetic Association 2025 guideline talking about management of hypertension, patients of diabetes. Talks about using the ACE inhibitors or ARBs as a first-line treatment for the patients of diabetes, identification of the patients have albuminuria or not, and based on what patient has findings, use the combination therapy right from the day one to control the blood pressure effectively. And just to remind you, in the patients of diabetes, controlling blood pressure is more important than controlling glycemia because the outcome depends more on controlling blood pressure rather than blood sugar. This is the Lipid Association of India talking about various kind of risk factors for patients with diabetes. They talk about very high risk patient, and moderate risk patient, and just look at the LDL targets, which are less than 15 very high risk patient and less than 17 high risk patient. In other words, your treatment in management of lipid is also aggressive, besides treatment of hypertension, which is also aggressive. This is the overview of the SGLT2 inhibitors, which Dr. Panikar did mention earlier, looking at 71,000 plus patients. Either they are the cardiovascular disease outcome patients or they have been renal outcome patients or patients of heart failure. But you see across the globe, across all the trials, you can see there's a benefit, whether it's a cardiovascular, whether it's a renal, or whether it's a heart failure. So these drugs have improved a lot of benefit in patients of diabetes in giving protection in the various problems the patients could have because of diabetes. And the important thing to realize this is the how do they help so much? If you look at the myocardium does not have SGLT2 transporters. It works through sodium hydrogen exchange transporter, and what it does, it improves the tissue biology. And what happens in patients of diabetes because of excess insulin and the adipose tissue expansion, there's the accumulation of the glucose and lipid intermediates in cytosol, which brings about increased stimulation of AKT pathway and mTOR pathway, and reduction of SIRT1 pathway, PGSC1 alpha, and FGF21. It is reversed by the SGLT2, and therefore you get benefit in the cellular outcome, and therefore these patients have better outcome in patients of management of various cardiovascular disease. And also important to realize that when you have patients of diabetes, there's excess glucose utilization by the myocardium, and therefore it brings about metabolic inflexibility. And when you use SGLT2 inhibitors, it improves the metabolic inflexibility by allowing the myocardium to use fatty acids, use ketones, and also interestingly now, the branch chain amino acids are also utilized effectively by the myocardium. And therefore you get the benefit of the outcome in patients of heart failure because of the substrate utilization efficiently and effectively, and therefore giving better outcome for the heart failure management. This is the data of the GLP receptor agonist, more than 60,000 patients. This is the 8 meta-analysis looking at outcome in the cardiovascular disease. You can see here there's a reduction by 14% in MACE, reduction in cardiovascular disease by 13%, also heart failure reduction by 10%, and therefore these drugs have really proved benefit in management in heart failure and the myocardial infarction in the diabetic patients. And we have these extended drugs, the GLP receptor agonist, like either a dual agonist or the triple agonist, which have proved benefit in not only reducing weight, but also reducing the cardiovascular outcome. Talking about the heart failure, there's a 5-pillar treatment in the patients, and these drugs have beneficial effect using ACRBs, neprilysin inhibitors, beta blockers, MRA, and the SGLT2 inhibitors have really proved very beneficial in managing the heart failure problems in patients of diabetes. As I mentioned earlier, the heart failure and diabetes are the two sides of the same coin, and therefore understanding this is important. And also interesting to remember that every time you use a drug like insulin or sulfonylurea, which may help the patient to gain weight, and when patient gains weight by 1 kilogram, the risk of heart failure increases by 7%. So therefore it's important to realize when you treat patients, see that the patient doesn't gain weight. And therefore the guidelines do mention that the use of these drugs, the GLP-1 and the SGLT2, in managing the patients of cardiovascular disease. If the patient has chronic kidney disease or a kidney involvement, then use the SGLT2, and use the heart failure, you can use the SGLT1, SGLT2, or also the GLP receptor agonist, especially with accompanying obesity. We have this STEP heart failure trial talking about the benefit of using GLP receptor agonists in patients who have obesity. If you summarize the various treatment modality that we have the CV benefit drugs, 3-point or 4-point MACE drugs. We have the metabolic benefit drugs and the renal benefit drugs. This slide does not mention the finerenone, which is also an important drug in the renal benefit. And if you look at the bottom of this slide, you can see that the agents proven to be saving lives in patients with diabetes are the empagliflozin, liraglutide, and oral semaglutide. All reduce the all-cause mortality and the cardiovascular death. So these are the important drugs. They give benefit to these patients much early in the treatment game, and not only they have the beneficial effect in cardiovascular outcome, but they also increase the lifespan and also prevent the dialysis by at least 12 to 14 years. So therefore, to take home message that what I said last 15-20 minutes, that the Indian patients have a type 2 diabetes are clearly at a high risk of cardiovascular disease. The cardiovascular risk assessment is the first and a simultaneous step in the type 2 diabetes screening and management. Aggressive management of risk factor control is recommended. Target of A1C below 7% in the most of the patients or 6.5 without complications of hypoglycemia and weight gain. ACRBs are the drug of choice for hypertension control. Gliflozins and GLP receptor agonists have immense benefits in the CKM syndrome. statins, don't forget to add every patient to diabetes with the age of 45 years. With this, I conclude my talk. Thank you very much for the patient listening.